Graham. The naloxone demonstration model was born out of the need that we weren't providing naloxone to service users, to patients, to clients, to users to prevent overdose. It is only opioid overdose that we have to keep in mind. So around 2005 I went to the Maudsley in London to learn about overdose, and in 2015 I finally got the Naloxone Project off the ground. So that's your timeline that I had to deal with. In that time I obviously looked at the Welsh model and the Scottish model, most particularly the Welsh model, because they had initially run out a demonstration project, which is what we did, looking at where high risk areas were, high risk patient groups, and in that we targeted very much our voluntary sector people, most particularly those who had a lot of homeless users who may not even be accessing treatment. We targeted Dublin city centre, north and south, Cork, Waterford and Limerick. And in that time, by the time everything got set up, we ran out training. We have 30 trained trainers for naloxone, and we've cascaded training down to over 1,000 people at the moment with regards who can cascade the training then out to family members and users. And that's the most important group in all of this. Not me, not anyone, but the service user and their family member or loved one. They're the most important people in accessing this product. So in May 21st, last year, the Minister announced the availability of naloxone, and we went live the following day, and the first prescriptions were issued for patients to access it. So since May to December, we have only issued, which is quite interesting, only issued 150 products. Now that might be because it's so limited to locations. However, the plan is that it's going to spread wider as more and more people take up the training. Whilst this was also going on, there was a change in the law. Any of you who enjoy reading the law, I think it's statutory instrument 423 or 324, sorry for my dyslexia, where they talked about availability of naloxone through that pharmacists could administer it, that a worker that had their project registered, that had done accredited training, could access it without a prescription. So again, it's a bit like the whole thing around law. It's going in the right direction, but it needs to be done a little bit more as to make it available that a service user can go into a needle exchange program and say, I need a naloxone, can you please give me one? And somebody can hand it over without a prescription. That's where I'd like to end up. But like everything, it's everything in small steps. And in that time, we've done an external evaluation of the project. And in that time, the other thing that's a very positive aspect of this is that it's been used, that we are aware and recorded on 5 occasions, and in those 5 occasions, there have been 5 saves. So 5 people have been saved. So you might ask, who carried out the injecting? Because I had huge issue with people giving out to me that clients won't know what to do. You know, they won't understand your training, Denis. It's too simple, too easy. You know, why isn't it more complicated? Why aren't we doing didactic 6-hour training sessions with clients to use a needle? So essentially the training for clients is, and we've got some star trainers in the room, is about 10 minutes at a push, maybe 15 depending on the client group. Family members take a little bit more because they have a lot of other issues that arise during the training, and we've worked in conjunction very much so with Family Support Network on that to roll that out amongst family members and for them to tailor the training for those. So we've had 2 peer-to-peer, and people would say, oh, they won't follow protocols. The peer-to-peer protocols and the answers back from talking to peers who administer this is as perfect as you could get from any examination. They followed everything to the letter of what they were told. Project workers reported back they liked the drill, as in because they said when Denis O'Driscoll and other trainers were giving training, they were very clear on a drill. There was a drill to this is what you need to do, this was your system that you had to put in place. So from our perspective, I think, I have to say, I think it's successful. For me, 5 people who may have died of an accidental overdose associated with opioids are not dead now.
Can I just add also that you mentioned Wales there. We were able to implement a very similar system in Wales back in 2010, and our records show that it's currently being used in 632 overdose events. So hopefully over time, we've seen only in the last year a 55% increase. So it does take a time, but it does become a faster moving vehicle over time. I think there's trust issues and lots of other issues, but it's really, really valuable.
Thank you very much, the two of you. Denis, you explained to me earlier that the formulation of naloxone is through injection rather than nasal formulation. I suppose, can you first just tell us exactly what naloxone is for anyone that doesn't know, and second of all, like, what is the two differences there, and why it is that you chose the injection formulation?
Okay. Thanks. Okay, so what is naloxone? It's essentially an antidote to overdose. But the most important thing to remember is it's not a treatment. It gives people time for the ambulance to arrive. And that's where we differ with some jurisdictions, particularly in the States, and that they see it often as a treatment, whereas we're seeing it as a time to allow the ambulance to come and take over treatment care. So at the beginning of this, there was a lot of issues around, the formulation you're using is an injectable, and needle stick injury, clients using needles, they'll use the needle for groin injecting, they'll empty out the naloxone and fill it up with heroin and carry it around with them and won't be arrested because the guards will see that it's naloxone. None of that has come to pass, believe it or not. Why we went for the injectable formulation was that at the time there was no marketed product in the world that was licensed for nasal delivery. There were organisations using the injectable formulation by putting a little device at the top for insufflation. But those organisations were doing that were predominantly ambulance. And my argument was, if I'm a mother or father at home or a partner with my loved one who's in overdose, I give them this waterboarding of this solution up their nose and they don't come round. I haven't an ambulance behind me to pick up the pieces. So in some ways, they have the luxury of having a mini hospital sitting on wheels beside them. And also, they have more product, because ultimately it would be one product. So the pre-filled syringe is what we went for, because also the beauty of this pre-filled product was that it had lay administration, extra labelling, which comes down to how they license the product in the UK. And by that, it meant that lay people, once they'd done the training, were able to administer it if necessary to people who needed it. So that was another positive step. Ideally, if tomorrow morning that there was a beautifully licensed nasal product on the market, of course that's the product of choice I would go for. But currently the product that is licensed and available and has been used in other jurisdictions, predominantly in Scotland, and I know in parts of Wales and in parts of the UK, in Sweden and in Denmark, that they use the injectable formulation. Once a nasal comes on the market, I'm sure both of us would be delighted to go down the route of looking at a nasal formulation rather than injectable, because then you avoid the whole issue of needle stick injury. The risk is somebody, that's the other thing that you get charged with all the time with the pre-fill. They'll go off and share it and won't use it for anyone else. But amazingly, when people listen to training and say that it's for one individual use, please only use it on one person. When you've used it, hand it over to the ambulance. In all the cases where we know it has been used, it has been handed back to the ambulance. So again, it demonstrates that when clients want to use it, and when service users and staff members want to use it, they do follow what they're asked to do. It's not that they become maverick and go around jabbing it into everyone in the hope that they'll save the whole world and everyone. So there was always that risk with it, but we do in our training cover very strongly about that risk and to be very mindful of it. And also the other thing is that if you talk about harm reduction, then we could argue that with needle exchanges, we continue to say don't share works. We do know that they do share. So then should we close down needle exchanges if we weren't allowed to use a nasal injectable naloxone? Thanks, Graham.
Thank you very much. And can I finally ask you, Denis, so this has been rolled out, already, through pharmacies and mothers, communities, and some other stakeholders as well. Can you maybe touch on where next? Where do you want this to be rolled out next?
Ideally, everywhere. Ideally, if you look at all the data, the statistics, if you look at a lot of the research, particularly in Scotland, by Bird et al., they would say that it should be 20 multiplied by those who've died of an opioid overdose. So we're at a little bit of, and this isn't a criticism, it's just the way our system works. Our overdose data is always behind. So you must appreciate that I'm working from data from 2013. In order to pick out where or actually when I was doing it 12 to pick out where best to roll this out. So that makes life a little bit difficult. So ideally, in my opinion, anyone who's been started on OST, most predominantly methadone, should receive a naloxone. Anyone attending a needle exchange that would say to you that I would like a naloxone should be provided with one. Anyone who has had a previous history of an overdose should have an naloxone. But not only should they get it, because remember, if they have it, it's all well and good, they're carrying it. You need to have the person who's with them trained in how to administer it. So there's a whole piece of work that needs to be done, and I know some organisations like Merchants Key and Anna Liffey Drugs Project particularly have been doing group setting training with clients. Not necessarily that they're getting the product, but just so they're aware that if a friend of them has this box, and sorry I didn't bring a sample along with me, but the box is very, very bright yellow, about this size, this thick. It's a very, very decipherable product. It can be easily seen that if they have this product and they see their friend in overdose, that they will give it. Also, interestingly, from Scotland, there has been some, you could argue, behavioural changes with clients who receive naloxone, that often they, if they're using with friends, tend to be much more cautious about how much they use, because they believe that they have the kind of service there in case one of their friends goes over. But again, very qualitative rather than quantitative, but it's interesting data to look at, that there is that whole piece that we need to look at, that there is a change modification around clients. The other thing, I guess, and I'm sure it will be the same in Wales, is that we need to encourage clients to carry it with them. If they don't have it on them, there's nothing, if you don't have it, can't save you. You need to carry it.